very warm welcome. My name is Daniel Reuter. I'm anesthesiologist and intensivist now from the University of Rostock in Germany at the Baltic Sea. And great pleasure to make this little workshop on hemodynamics together with brilliant colleagues, with Azrael Perel from Israel, David Kaufman from New York, now from NYU, and Xavier Monet will join us as well from Paris. He's just giving a lecture in another room, and we will get this workshop together. What do we have on our agenda? We will start with some very, very short presentations on the topics you find in the agenda. I will start with a few words on different non-invasive or minimally invasive monitoring techniques. I think everybody of you is familiar with the invasive ones we are working on a clinical basis. So I put my points a little bit more on the non-invasive part because we don't use that so far on a frequent basis on the ICU. And then Azrael Perel will speak about a very important point, fluid responsiveness, how to deal with this in invasive and in non-invasive forms. And then we will get into measurement details, how to perform a very good measurement, the tips and tricks. David will do that. And we will talk about influences on functional hemodynamic monitoring and get also the clinical context. In the end, we want to do a case scenario together, and it's really, please interrupt everybody of the speakers if you have a question, then because this is really the opportunity. We don't want to have this format, just one is giving a presentation and all the others are just listening. Okay. Non-invasive or minimally invasive monitoring techniques. First of all, who's working on an ICU, and who's working in the OR? Okay. I think in the OR we are using a little bit more frequent already some minimally invasive monitoring techniques. But I think maybe in the future this will change also. This will go over also to the ICU. So I think this is a topic worth to think about it. Well, these are my conflicts of interest. So I'm sharing my ideas with some monitoring companies. So about hemodynamic monitoring technologies, the most important ones I think are on a daily basis blood pressure and cardiac output. And of course we can do that invasively and continuous with the classic ones and very, very specific also regarding cardiac output monitoring. But well, of course, with the invasiveness, also the number of complications and also the resources we need for that go up. So the idea is basically to get this as precise as possible, but as non-invasive as possible. This was also wrapped up by by many clinical reviews. This was one published actually already a couple of years ago. What is the ideal hemodynamic monitoring system? Well, you see the list here. It should be, it should of course provide relevant variables. It should be easy to use. It should be readily available, and it should cause no harm to the patients. Well, with continuous non-invasive blood pressure monitoring and cardiac output monitoring, we would exactly reach these goals here. I think the most important ones, but another very important one actually has to be questioned when you get some new technology on board, and this is actually, is this accurate and reproducible? Does it really measure what you really want to measure? So Bernd Sauger, a colleague I've been working with together for now already many years, he wrote that in an editorial also already a couple of years ago. No, I think it was in 2014, a couple of years ago. So the question, are we ready for non-invasive monitoring techniques? So it's the question of measurement performance and, on the other hand, the practical applicability in clinical routine. And what do we have available here? And I think I don't want to go through all of this, just a few of them. We use them, I think, as I mentioned, much more frequent in the OR. Who's using one of these technologies in the OR besides invasive blood pressure monitoring? Nobody? One? And the others? None of those technologies? On the ICU, I think this is quite frequent. Well, okay, partial rebreathing, bioimpedance, pulse contour, Doppler. I think the most well-known and the most used is pulse contour analysis. And during when you think about it, it's a technology, an idea which came up already more than 100 years ago, nearly 150 years ago. The first publications were 1899 in physiology, the idea to get some more information out of the pulse contour for monitoring. And then it really found its way into clinical practice when we got this computerized and automated. And I think it's an ideal situation because on the one hand you get this information on blood pressure, where we are all focusing on when assessing the patient hemodynamically in the first round, whether this is good or not. I think that's another question. And you can get out a lot of other very important values, and I think the most important one in many clinical situations is cardiac output. The idea behind it, we have different monitoring techniques, monitors from different companies, different technologies, how to assess the pulse contour, radial, femoral, invasive, non-invasive, semi-invasive, but the idea behind it is always exactly the same thing, that the systolic portion of the curve is, well, the area under the curve, the integral is calculated, and this area under the curve is in close association with the stroke volume that is provided. And whether this is done by an algorithm that takes into account the whole thing and approximates then again the systolic part, or it's just measuring really the shortcut, well, the clear cut, the systolic portion, or other algorithms, the idea behind it is always exactly the same thing. The stroke volume is calculated, and then the cardiac output is calculated, stroke volume times heart rate. Well, we can do that invasively in the radial artery, in the femoral artery, in the, I don't know in which artery, everything, actually in all arteries, or we can do that non-invasively. Non-invasively here, for example, well, with the volume clamp methods, I will come to that in a second, or even, I think Azrael will talk about it a little bit later, we get this pulse contour in a way, and we can get also some information out of it, well, from the platysmographic signal. So this is, I think, one of the technologies that has come up in the OR during the last already more than 10 years, but is really getting into more and more into clinical practice, and this is the volume clamp technology. Basically, what is happening, well, there's a finger cuff which puts pressure on the finger and lets the arterial blood flow here through the finger artery just pass through. And this is checked with the platysmographic signal at the tip of the finger, and the pressure that is needed actually to allow just the arterial signal to come through is continuously measured and transformed in a curve. And by that, you get actually a pulse contour, and it looks like exactly like an invasive signal. Different monitors, I think those are the two monitors available right now, which are basically from the technology exactly the same thing. Here the finger cuff, which you can put through. Well, the anesthesiologist who is using, is somebody using that on a frequent basis? Yes, we do that as well. It works in many situations, in many patients, it works quite well. If you don't look at the patient where the artery is positioned, then you could frequently think, well, this is an invasive arterial pressure signal. Well, it is easy to apply, but exactly the question, how reliable is this signal? And when we look at these monitoring technologies for continuous blood pressure monitoring, there are already many studies available. So this was one of the meta-analysis, the recent meta-analysis regarding that, and I think we don't need to go through that. But of course, these are for the different monitors. There are, when we zoom in, there are some very good-looking studies with very good results. But on the other hand, there are also studies exactly the same thing, where actually the results are not as perfect. And exactly the same thing, I think we don't need to go through that. That's for cardiac output monitoring. There are only a few studies available so far, because actually putting pulse contour algorithms on this signal has not been performed for too long. There are some good studies, but again, when you look here, and I think the most important or the most easiest message is always in this percentage error that is given here, and roughly we say everything that is higher than 30 is clinically at least problematic. And you see here in this study, for example, a percentage error of 58%, or here down here of 57% in critically ill patients, for example, here. This makes it at least worth to think about it, whether this is really the ideal tool to trust for your therapeutic decisions. Also, I think we can skip that. These are studies, just recent studies, showing with the different non-invasive technologies, and you always find here percentage errors which seem to be quite high. But honestly, when we compare that to invasive measurements that are performed in the periphery, in the radial artery, and when we look into the studies that are published on that, they are quite close also to those values. So the difference between peripheral invasive signals and those non-invasive signals, the differences are not too big. But still, I think we cannot say right now for sure that actually we can use that for each patient. Why is it so? And I think why is such a monitoring technology, which is basically from the physiology, which should work, why are those differences in clinical reality quite often to see? Well, this is of course because of the limitations, of the technical limitations of the different systems. And of course, when you want to analyze a pulse contour, well, you need actually the real pulse contour and not a damped signal. So it's quite easy to understand if you have a damped signal that this area under the curve will change. And of course, when I want to use when I want to use the cardiac output number and I have severe arrhythmia, then of course this cardiac output signal will not stay constant comparably, but it's very influenced, of course, by the severe arrhythmia. Another thing is, of course, with all pulse contour technologies, the changes in vasomotor tone will change this curve, and this will be different in central arteries and to peripheral arteries. So, and another thing that makes it much easier to use in the OR, but more difficult in the ICU when we have patients that are already on their way to get awake again, it's of course the movement of the patient. This will destroy the signal, and also in critically ill patients, when I want to get some signal here from in the periphery, non-invasively, and the finger is swollen, the finger edema. Well, with some edema, this will make it even harder for the system to get out really good signals. So very shortly about bioimpedance, bioreactance, another thing that is currently pushed to monitor also cardiac output in critically ill patients. The idea behind it is that the impedance to an electrical current that is applied through the thorax is changing when there are different amounts of blood within the thorax. So the impedance is continuously measured, and if there's a stroke volume going through the aorta, then actually the volume of the blood is increased, and blood has a different impedance as the other contents of the thorax, and this is mainly air and a little bit of tissue, but mainly air. Well, then this impedance change is related to the volume, to the stroke volume, and this is the basis of monitoring stroke volume with bioimpedance or bioreactance. Well, this idea is used also for other, this technology is also used for other questions, for other measurement purposes. And theoretically, I think it's a very brilliant idea because it's completely non-invasive, and it is central hemodynamics. It's not the hemodynamics in the small toe of the patient, but it's really that what I want to change in patients that are that have acute cardiovascular problems. But the influences that, or the factors that influence impedance in the thorax are manifold, and also the signal that is caused by the change in stroke volume is compared to all the other influences quite small. And this also explains why in very, very perfect conditions, maybe the results are not too bad. But actually, in the clinical reality, you see here, in the clinical reality, and in particular in the critically ill patient, the error becomes quite frequently quite high. We see that here. Well, I just put on here some of the factors, by far not all of the factors that influence the impedance changes within the thorax, and this is, of course, well, the biggest organ in the thorax it's the lungs, and so everything that is associated with the impedance characteristics of the lungs will, of course, change also the results regarding hemodynamics. Well, partial CO2 rebreathing, the fixed method, I think we can go very quickly through that because it's a very, very old method. It is experimentally actually one of the reference methods we can use to measure cardiac output, and also the clinical studies with available systems are quite good, but, well, it works only in intubated patients, and those points that influence the measurements we have frequently in our patients on the ICU, because that's the reason why they're on the ICU, and therefore it's quite difficult actually to use that on a frequent basis on the ICU. Pulse wave transit time, another thing I think we can go very, very quickly on that. The idea is actually to combine ECG monitoring with pulse oximetry and to use actually the transit time. The start is shown by the ECG, and actually the waveform of the pulse oximetry shows us when it arrives in the periphery. But from a practical point of view, at least the monitoring, the monitors that are currently available regarding that, the studies were not really convincing so far, but maybe this might be also a technology that will come up in the future. Of course, also here, all limitations that are given for monitoring techniques that are applied in the periphery. So to conclude that here at that point, are we ready for the non-invasive technologies on the ICU? I'm quite sure, I completely follow here Robert Thiele in this editorial a couple of years ago, that it's only a matter of time whether we will monitor all that stuff non-invasively. But regarding the central hemodynamics, I think we are so far, for the critically ill patient, there's still a way to go, and we will need our invasive monitoring techniques so far. I think where we will start, and I think this is a concept which everybody should think about in his or her own patients, we need for our monitoring, for advanced hemodynamic monitoring, some form of step down, step up. We have patients where we clearly need maximal invasive monitoring, but those patients get better, but they still need a closer look on, and then we can actually step down in those patients regarding monitoring. And there are also patients that will need a step up, where actually it gets more complicated, and then we have to increase the invasiveness of our monitoring. So I think right now, and we had 2 years ago, nearly 2 years ago, we published a consensus paper out of the cardiovascular dynamics section of the ESICM, where we wrap this up for the current state of the art. This is very promising regarding the non-invasive tools, but still for the critical ill patient, for the severely critically ill patient, I think we need some more data, and we need some more improvement to really base our therapeutic decisions completely on that.